Great pleasure to be with you this morning. I'm going to start with almost an advertisement, but because I am out here, as they say, to recruit you. And there we go. So it's very exciting to have this audience on board. And I hope everyone is aware that the issues of transition and also access to high quality adult care have really become priorities for both our advocacy and research work. And I want to let you know about a project. And just to set it in context, I think we're all very aware that the story of OI is changing all the time. Our expectations have changed radically. As a pediatric orthopedic surgeon, bisphosphonates, good rotting have really enabled me to help kids in ways I never dreamed of when I started out. Pulmonary concerns have made us all worry, and there are numerous new medications on the horizon. So the issue is, my golly, we don't fully know the natural history, and anyway, it's changing. So what are the key questions that need to be answered? And how do we involve the entire OI community in answering them has become a priority issue for us. We were very fortunate to receive a PCORI award a while back, and we've started to work away at that. And one of the messages that has been loud and clear is that we need to pay more attention to transition and the access to care issue for adults, or really the lack of it. So we are very pleased. We have gotten yet another PCORI award. Has a long-winded title, but the issue is, how do we improve transition and how do we improve that access? So what are we going to do? Well, first, we're going to talk to everyone who's willing to talk to us. People with OI, caregivers of individuals with OI, other leaders of rare disease organizations, because they're facing the same problems. Nobody knows what the adults really want and need. And we want to invite everyone on this call to join us in this journey. We want to have listening sessions, and we're going to have a lot of them, where we just have 5, maybe 6 people talking about what they feel the issues are. We want to explore the gaps and what are the opportunities for the foundation as we work on these problems. What does the community really want or need? Should we establish centers of excellence, or will it be too hard for people to get there? Is the community open to peer coordinators? What is the potential role for telemedicine? The government has been very strict about that in the past, but COVID opened people's minds. What can the OI Foundation actually do? Should it be training coordinators? Should it be developing standards of care? All of these issues and many more are on the table. And one of the critical reasons we want to talk to so many people is to be sure no issue goes unidentified. Our long-term goal is to create a possible strategic plan for the foundation that capitalizes on these findings. Because we need to help them develop a strategy that will both capture this rapidly changing story, not just for the minute, but for the long term. So what do the next 50 years look like for OI? I certainly don't know. And there won't be a lot of immediate answers, but we need participation from all willing individuals. It's like your 401k. We just got to put a little more till we really develop better solutions. So please let your voice be heard. If you want to talk about what we're doing, please contact Stacy Loring, who's the backbone of this effort, and her email is right there. Or for more general information, please go to our PCOR, Patient-Centered Outcomes Research website. But we need you, we want you. Here's an old World War II recruitment poster. Are you doing all you can? I think we're hoping that you'll think part of that is helping us out. So that's my little advertisement for the morning. And now let's get started with the program going forward. Thanks, Michael.
Great. Thank you so much, Dr. Tosi. Now I would like to introduce Dr. Lindsay Nicol, who is joining us from Shriners Portland, and she will be talking about this complex issue from the pediatric side. Dr. Nicol, thank you so much for being with us.
Thank you, Michael. Thank you, Tracy. Thank you, Dr. Tosi, for the invitation. Is everybody able to hear me? Thumbs up. Okay, good.
Sounds good to us.
Pass that test. Let me see if I can share my screen properly. All right, are we on?
Yes, looks good. Thank you.
Okay, thank you. So I am a pediatric endocrinologist, and I have been interested in bone health for children for the last half of my career. I've been at OHSU as an associate director or associate professor, and I love bone health, and I love taking care of patients with osteogenesis imperfecta. It's why I get up in the morning and do what I do. You might be wondering how Peds Endo gets involved in bone health, but there's a lot of hormonal signaling that's involved with taking care of bones, and so I help with a lot of the medical aspects of OI care. So I'm not a surgeon, but I try and prevent surgeries, prevent fractures. In Oregon, I work at a lot of different venues, but I'm most closely associated with OI Health through Shriners Hospital, Portland, Oregon. So we're way over here on the East Coast or on the West Coast. And I pull up this map in my background because it's one of the major issues with care is that we don't have a lot of high density of hospitals on the West Coast. So our patients do a lot of traveling. I'm associated with several hospitals. I mentioned Shriners. I'm actually housed under the Oregon Health and Science University with Dornbecker Children's Hospital, which is a tertiary referral center with all the subspecialists. It's like a major university for Oregon. And I do a lot of things to engage in OI care. I do prenatal consults. So I work with our fetal therapy program. I work with our NICU, our DEXA program. So many of our kids who are highly affected with OI and the parents want to start treatments with bisphosphonates early, we coordinate those care, and I coordinate that care in the NICU with experienced pharmacists and protocols for infusions. And we also have a very highly trained densitometry staff for reading bone densitometry or bone density scans. So a lot of consolidated medical care at a single location for Oregon. Within the OI clinics at Shriners, I'm in a really, really lucky position because it's a multidisciplinary clinic, and that's exactly what kids with osteogenesis imperfecta need. They need people who are expertise in multiple areas of medicine. So within that team, there's a geneticist. So this is the place where most of our kids are referred for the suspected diagnosis, and we help the family sort that out. Ongoing care with mobility and transfer issues and recoveries from surgeries are handled by our PT and our OT team that are highly experienced. Of course, we're working with orthopedic surgeons, social worker. I think one of the key players in our clinics is our nurse care coordinator, because there's a lot of care coordination that needs to happen between specialists and getting kids in and making sure things are happening with their health care. And then there's me with pediatric endocrinology, and my role is often, medical intervention for those kids who qualify. I run bisphosphonate infusion plans at multiple places throughout Oregon, including outreach centers for those with major mobility issues. Additionally, there's acute care. Acute care means something happens right away and you need to see a doctor right away. We have fracture clinics. And of course, we're also lucky enough to coordinate with the OI Foundation and the BBDC, the Brittle Bone Disease Consortium. And we have research opportunities for those families who wish to participate in those. So a lot of things going on for kids. So what happens when kids outgrow our system? Well, that's the next big thing that gives me a lot of anxiety. I'll be truthful about that. And I'll be very interested in participating in this panel because I don't think we have a lot of those things sorted out. But to just give you some background on what happens in Oregon is that we consider pediatrics up to the age of 21, and we generally hold on to our kids as long as possible because that's ideal. A lot of them are transitioning outside of the house at this age. A lot of them are transitioning to college, and we want to kind of keep our hands on them until we can make sure that they're ready, mature enough to move forward. We are lucky in Portland because the adult practitioners are experienced in OI. Our orthopedic surgeons are generally experienced in OI, and we also have 2 endocrinologists who are very passionate about taking on patients with osteogenesis imperfecta. So I have a lot of transition care, which I call a warm handoff, and I know the people who the endocrinologists are who I'm passing my patients off to and transitioning to, and they're very happy to do a lot of care coordination that's required. And so I think that's I'm really lucky in that sense. And OHSU is known for its strong bone and mineral program in adults. And so we have a lot of experts there in bone disease. In some situations, obviously, where kids are not going to be able to stay in Portland, we sometimes will get a social worker involved to sort out and fill out insurance issues, transfer of care, and who are local providers. But we certainly don't have that system fully worked out. So we have a lot of advantages at OHSU, but we also have the same disadvantages. Again, we go back that we are a referral source, a referral from a large regional area. Access always remains an issue for our patients. We are starting to explore things like telemedicine, but even those have some limitations. And so this is an ongoing issue that needs a lot of work, a lot of input from smart people. So with that, I will stop sharing and go to mute.
Great. Dr. Nickel, thank you so much for that. And we really appreciate you joining us. I want to move right along and introduce our next panelist for today's session. That is Dr. Sandesh Nagamani. He is at Baylor in Houston, Texas, and he runs a adult OI clinic there. Dr. Nagamani, thank you so much for joining us.
Thank you, Michael. Am I audible?
Yes, we hear you loud and clear. Thank you.
Perfect. So let me try to, I have a couple of screens and I'm struggling to sort of share. Give me 1 second. Okay, I'm assuming you can all see my screens, and I'll hide my floating panels. Okay, am I audible?
Yes, thank you.
Perfect. So again, thanks to the OIF and Dr. Tosi and Tracy Hart and Michael for arranging all of this. And I'm gonna, what I was tasked to talk about was what should patients know or bring with them to sort of make their transition a bit more efficient than it is. I am an associate professor and vice chair for clinical research in the Department of Molecular and Human Genetics at Baylor College of Medicine. I'm a geneticist and internist, and I take care of adults with OI. And in my genetics clinic, I do have a sizable number of patients with OI. Now, just as Dr. Nicole mentioned, her large academic center, I'm also fortunate to work within the context of the largest medical center in the United States, the Texas Medical Center. Only a part of which is visible here, employs over 100,000 employees, has 50 member institutions, and accounts for almost 10 million patient visits a year. The campus is spread out on 5.5 square kilometers of space. So though it's one campus, I do not visit many parts of the campus for months together. Now, because of the large Department of Genetics as well as large pediatrics hospital, again, I'm lucky to work with a fantastic and outstanding group of experts who take care of children with OI. I'm sure you do recognize some of the names that are world leaders in skeletal dysplasia and OI. So we do have the skeletal dysplasia clinic that runs out of Texas Children's Hospital that caters to children with genetic skeletal disorders, including OI. And it's a multidisciplinary clinic that has genetics and orthopedics. We have a skeletal radiologist who assists with the review of the skeletal films. We have clinic coordinators, and TCH has other specialists that would provide the multidisciplinary care. I do think that, all across the United States, the pediatric care within a larger academic center is a lot more centralized, where patients can get access to the multiple specialties that they would need. However, what happens when they transition to the adult facility? So this is the adult McNair Hospital, where the adults with OI are taken care of. And for patients who are transitioning from Texas Children's to the McNair campus, I think we also do have what Dr. Nicole referred to as a warm handoff. The pediatric geneticists who are caring for these individuals do call me and provide a detailed overview of what they think should be done. And because the clinic wait times in genetics are not reasonable, we do overbook them and get them earlier. So in the adult clinic, again, we do have a group of individuals, myself, a nurse practitioner, genetic counselors, as well as access to other Baylor Medicine specialties, including orthopedics, audiology, and physical medicine and rehabilitation, and others. And I, again, have to be honest, in spite of this being what I would like it to be a warm handoff, many occasions it is less than warm, just because there are complexities associated with what the private medical practice will accept as insurance. So especially if there are individuals on Medicaid and Medicare, they may have access to one specialty but not the others. And also the adult specialists such as orthopedics, pulmonary medicine, and others we do not have individuals who are focused on OI care. We have individuals with significant experience in orthopedic surgery who do take on the task of managing patients with OI, but unlike in the pediatric settings where we have dedicated orthopedic surgeons specialized in OI, we do not have the same, and that sometimes can be a challenge. Now, some of the common transition of care issues that I have heard in the clinic is this from the patients, especially if they've come from remote areas. We again do see patients from Texas, Oklahoma, Louisiana, Arkansas, and sometimes even farther away. But for individuals who come in, they do say that their providers have limited experience in the management of OI. And these are quotes that patients have provided. One of my favorite ones was, "My doctor thought I didn't have OI because I went into the office walking." The challenge that I think I face is that adult hospitals are not equipped to perform procedures and surgeries. Adult anesthesiologists may not have all of the information regarding how to manage them, or even the endotracheal tubes and the necessary equipment that needs to be modulated based on patient sort of size. So whenever they're transitioning, the overall goal that I have is to sort of get an idea as to where they are that will help coordination of care. So what patients may want to know from their pediatric providers and have access to before transitioning is this: please know what your type of OI and gene mutation is. Please know the type of treatment for the bone disorder that you've had. What infusions have you had? How frequently have you had? And what did that actually do? How much did your bone density increase? Did it decrease your fracture rate? If you have these sort of information, it will really be important for us to decide what the further treatments would be. A thing that my orthopedic surgeons have repeatedly told me is they would really like to know the procedures that have been done at Texas during the pediatric hospitals. Though it is one large medical center and Epic does have care everywhere, not all of the records transition smoothly, especially the imaging records. So we can get static reports of x-rays, but we cannot get actual images to be seen if it's not done within our facility. So having access to this and having CDs of the most recent images, be they skeletal surveys, spine films, or bone density scans, would be important for your adult providers. If there are plans for surgical intervention, it would be great if you have a plan outlined by your pediatric orthopedic surgeons, which can be communicated with the adult orthopedic surgeons if the pediatric facilities cannot perform the surgeries. Similarly, for the extraskeletal information about what sort of teeth abnormalities you have, whether you do have malocclusion or not, and what has been tried to sort of take care of the dental abnormalities. And if there are cardiopulmonary issues, have you had an echocardiogram? What were the results? Have you had a pulmonary function test or lung function test? And what were the results? And if you have hearing related issues, has there been an audiological assessment? And what's your vaccination status? Have you been vaccinated for COVID-19, for pneumococcal pneumonia? Have you been vaccinated for the influenza for that year? These would be important for a transition so that we can, as adult providers, we know what care access you may need. Finally, the idea for all of us would be to sort of establish a care team. This is easier said than done. Your home team should be a medical therapy team. This could be led by any individual with expertise. At our center, it's geneticists. At other centers, it is orthopedic surgeons, it is endocrinologists, it's internists, and transition medicine specialists. So if you have one home that will end up finding appropriate services for you, such as pulmonary care, orthopedic care, audiology, PM&R, and others, this would be important for coordination of care. So I will stop here and stop sharing my slides.
Great. Dr. Nagamani, thank you so much for joining us and for providing this really essential adult provider perspective of this transition of care topic. I want to introduce now our next panelist. So Tracy Mulroy is a longtime volunteer and advocate for people with OI. She is actually one of the first people I met at an OIF conference. I'm not going to say when, and because it ages us both. And I want to just thank her for joining us for this panel session. Tracy, thank you so much for being here.
Thank you, Michael. Thank you for not saying when that was. um, my name is Tracy. I live in Bethesda, Maryland, so really close to the OI Foundation headquarters, which I don't get to see too often or often enough. I have OI type 3. I have a son with OI type 1 who is currently navigating a transition from pediatric to adult care. So not only have I been through it myself, but I am navigating it with my son now as well. I am currently on the board of directors for the OI Foundation, and this is my second go around. I was on like 15 years ago, so I guess I did date myself. I am extremely passionate about OI adult health. Some of you may know Jamie Kendall, and for those of you that didn't, she was a beloved member of our community, very passionate about OI health, and a very dear friend of mine. And she died at age 42 from respiratory complications during just a routine endoscopy, something people have every day, and they don't even think about. So that really lit a fire under me. And I started the Jamie Kendall Fund for adult OI health with the incredible support of the OI Foundation. And we've raised, I think, close to $500,000, if not $500,000, and funded the first really groundbreaking pulmonary study into why people with OI are dying at high rates from pulmonary issues. I'm not a doctor, so I'm not going to delve into the results of that study, but you will hear more about it in the Ask the Expert panel sessions later today. But I will say that the results have been, I think, very surprising to people, in that it's not just scoliosis that is causing the problem, as people I think have long thought. And I think that, sorry, I'm just looking at my notes here. One of the things that I think is really important, and the other panelists before me have touched on, is that OI is not just bones. And as you age from pediatric care to adult care, it is extremely important that you know that, and that you are able to advocate for yourself as best as you can. And you go in armed with that knowledge already. I also am really happy when I find a doctor who's willing to say, you know what, I don't know everything about OI, but I'm willing to partner with you. I'm willing to call the OI Foundation. I'm willing to call other experts in the field to learn what I can. When I go to a doctor who pretends that they know everything, and I ask them how many OI patients they've seen, and they can hardly spell it, that is like red flag, run, do not walk, wheel fast. I was just recently in the hospital, and I live in, right outside of Washington, D.C. NIH is quite literally down the street from me. And I had a very serious fall. And the lack of quality care that I received was astounding. I was at an institution that is under the banner of Johns Hopkins. It was not Johns Hopkins because I could not get the ambulance to take me to Johns Hopkins, which is another issue people have touched on, is actually getting the access. And they wouldn't transfer me. So it was a really difficult thing. And I'm on the board, and I lived close to all these amazing medical centers. So the lack of care, even in orthopedics, became really, really apparent to me. And the clinic that I attended was headed by an incredible person, but who retired. And the clinic sort of had to start all over. And we need clinics that are more well established, where we have younger people coming up that are learning, so that the retirement or somebody moving on to something else doesn't cause an entire adult clinic to collapse, or be able to offer less services, I guess. So that's something that I really, and this is going to take a community-wide effort. We cannot do this. The Jamie Kendall Fund is probably, a few hundred people every year donating, and that's been amazing. And it's really been an amazing start. But we really need everybody pushing this and pushing to know more about what goes on in adults with OI, and pushing for better OI care, and pushing to advocate and arm yourself with knowledge. I think that's all I have for right now. I'm happy. Sorry, I don't have slides. If anybody wants to contact me off whatever, the OI Foundation has all my contact information, and I'm always happy to talk to, anybody offline. Thank you.
Thank you, Tracy. As always, it is so great to hear from you and to hear your perspective on this really important topic. And we're so glad you can join us. So now we have heard from all of the panelists who will be with us today. You can see my colleague, Jessica Ransom, is putting up a new set of slides here for us to look at. I'm going to just introduce Jessica real quick, and then I'm going to hand off the session to her. So Jessica Ransom is the OIF's health educator. She is the person who, if you email the OI Foundation at bonelink@oif.org, 9 times out of 10, she is the one responding to you with any type of OI-related inquiry. So if you are looking for feedback on a specific issue, she can help you with that. If you are looking for a referral to a medical provider in your area, she can help you with that. And she is the person who really sees the types of questions that the foundation gets related to not just this topic, but all topics. And I am so happy that she is going to be presenting some scenarios, but I will let her introduce that a little bit more. But Jessica, thank you so much.
Thanks, Michael. So I also want to piggyback on what Michael said. The next week, we often see an uptick in inquiries following conference, which is amazing. I'm actually going to put my contact information in the chat as well as a link. I'll be doing, so I have office hours every Tuesday and Thursdays, which is a dedicated hour on Zoom with community members, and we can work on finding medical professionals in your area, or anything that may come up is literally a dedicated hour on Zoom. So I'm going to be doing like an all-day office hour concept every hour, so we can just keep the conversation going about, transition of care and working together to finding those resources in your immediate area. So I am going to get started with our scenarios. So scenario 1. I am 17 years old, entering my senior year. My parents and I have navigated a balance and responsibilities with my care throughout my adolescent years. My dream school is not within driving distance of my hometown. I am apprehensive about going out of state to school. Do you have any tips for navigating care while in college?
Who do you want to take it? I don't know how.
Yeah. There's no specific order or anything like that for the panelists. If you feel that the question applies, feel free to answer. I'm not going to call on anyone, but if it's something that's, more directed for a specific individual, I will. But yes, feel free.
I would make a few comments since in my pediatric orthopedic role, this comes up relatively often. And it first starts with this choice of a school. I would be less than honest if I didn't say it's always great if I can get kids to go to a school that's near a large medical center, simply so there's a good chance of having someone who knows a little bit, at least, about OI available. I do extensive letters for my kiddos. I am an individual who survived a house burning down, and I want my kids on the first floor, or with as little access issues getting in and out of a building. So actually, I write letters once the kids are admitted to their college. Forget about the healthcare. I just want them to be safe all the time. And so choosing campus living, I think, is very important. I do think it's very important for the kids as they look at their colleges also to be careful. Is there a whole lot of walking? And frankly, if so, is there a lot of snow and ice? Because I have had kids packaged up and sent back to me after they fell on the snow and ice. All those are very important. I think it is important to let the school health system know that you're there as a young adult and really try to establish a relationship with the school health system so they can be your advocates if an emergency arises. When I'm really lucky, the kids go to school at a university or near a university where I know the OI experts. And I'm always glad to send an email that says so-and-so is coming to town. I'm most hopeful that they won't need you, but I just want you to have that name ready to go. And I certainly urge the kids to have everything that Dr. Nagamani really was talking about, or maybe not everything, but certainly a basic list of what operations the kids have had, what hardware they have in, if they have hardware. And it is every kid's right, once they're 18, to demand a copy of their x-rays. And I think the really astute college student has a CD of their x-rays should an issue come up. So I'm very fracture oriented. I cannot tell a lie.
Thanks, Dr. Tosi. I really like the point that you made about making those relationships with the student health services. Also, in addition to like the student health services, really making it a point to connecting with the student accessibility services. So reaching out to them as well, that's also a great point. Are there any other panelists who would like to chime in on this scenario?
This is Lindsay. I think the only other thing is, clearly sometimes moving off to college is not a great time for a kid to transition to adult, and I wouldn't encourage it during this time. But when I hear this information, usually my next question is, are you going to be home for spring break? Are you going to be home for winter break? And making them like get their follow-up appointment scheduled then so that they can get back into clinic and see their providers during those time periods. So that's another thing to be potentially proactive about before leaving off to college or out of state.
Definitely. Just to combine sort of what Dr. Nickel and Dr. Tosi stated, it's almost as if you're creating a safety net of resources for that transition, and really planning around that transition from the high school environment into college.
I would want to second what Dr. Nicole actually said. We have the same. I also am a part of the urea cycle disorders consortium, and children with urea cycle disorders who can have devastating metabolic complications when they have to transition into college. That's the one thing that we also bring about, is how sort of what your schedule would be. When will you come back to get your treatments modulated, and who would the contact person be at your local home institution who would still be able to guide individuals across state lines about what one needs to do. The one frustration that I would like to bring up as a medical professional is, because of the way medicine is practiced, even though telemedicine would be possible with a team that you've already established at your home city, if you're outside of the state lines, by compliance laws, we can't even give medical advice, though you're established patients. So one good thing would be to find a local provider who would be interested in getting input from your home team to manage the acute events once an individual were to go to college.
Definitely.
Can I just add something too?
Sure.
I've done this. You know, I did go to college out of state. It was driving distance, but it was far enough that I wasn't home. So I guess I want to just throw that out as a really viable option, is to, you know, if you can find somewhere that, even if it's a little bit far, but you still are away from home, you get that real rich college experience, but you're close enough that if there's an emergency, you know, you have your home. The other thing I'll say is that for me, and I think a lot of OIers, this time in your life is a season where you stop breaking as much. And so for me, I was kind of like, I just buried my head in the sand and went off to college and dealt with it when I had a problem, which I really didn't have, luckily. So, you know, it's of course better to prepare, but if you have a kid that just doesn't want to deal, you know, you'll figure it out.
Definitely. And, you know, when those certain situations do arise, the foundation is, here's a resource. If you do find, well, let me say, when you do find someone in the area of your school that is willing to connect with other medical professionals or get input, we can serve as that connector, bridging the gap between the two medical professionals and connecting them with someone who is experienced, you know, within this field. All right, so we're going to move on to our second scenario. I have a few months before coverage under my parents' insurance plan is up. I've been with my primary care doctor for 2 years. My primary care doctor has been extremely helpful with my care and is constantly looking to learn more about OI. I am worried that the change in insurance plans will cause a disruption with my care. How do I navigate this?
I'll start.
Sure.
I'm always willing to chat. This comes up for me slightly differently. And for me as an orthopedic surgeon, the first thing is, what is the new coverage going to give you for durable medical equipment, which is sometimes just as important as the primary care doc, simply because the costs are so great. I think that most primary care physicians are on multiple panels. And this is really a detective job. If you really love this primary care doc, then you need to find out what insurances they're affiliated with. And as you look at your options in healthcare, where is the overlap? It isn't 100%, but if you're staying in the same geographical area, with luck, you can find an insurance plan that has what you need and that this doctor is affiliated with. Not always.
Right. So really just taking the time to do that research of, you know, looking into what insurances, what type of insurances the provider takes and really matching it up to, you know, the available insurance options that you may have. So really just doing, you know, taking the time to do that research. Does anyone else on the panel have any input for this scenario?
I'm just going to quickly, Michelle Kramer, thank you, because this is a really good point. Be sure to check your parents' insurance policy, as ours has a clause that if the child was permanently disabled, you could apply to have the child on the insurance policy for life. We were successful in doing that. That is absolutely true, and particularly true for my military kids. So look at every option here. Great comment. Thank you so much.
The only other resource that I think that families can use is don't forget about your social worker. They're not just for, you know, I mean, we use social workers for a lot of things, and one of them is to help families and patients navigate insurance and make sure that they're properly signed up for insurance. So they can be utilized as sources in some cases like this in helping families figure this out. So.
Definitely great point, Dr.
I can just also add that I had a doctor who, a smaller practice, who I loved and who, really liked, enjoyed seeing me and learning about OI. And they were changing insurance, or I was changing insurance. And I advocated, and they actually got on the insurance panel that I was switching to. Not all doctors will do that. That's a special doctor, but it's worth a try. Advocate, advocate, advocate.
I love that.
Great.
All right, for our next scenario, my daughter is 16 years old and I have served as navigating her care since birth. I am her caregiver as well. Recently, she mentioned that she wanted to share the responsibility in making decisions about her own care and choosing doctors. How do we begin this sharing of responsibility?
Oh, I'll go first on that. First of all, if I hear this, I'm very excited. I'm very excited because this is a really good moment and a really good age to start talking about that, especially if the kid has brought this up themselves. Then I would highly recommend moving forward with including your kiddo in healthcare decisions. Clearly, if they're talking about it, they're old and they've developed the mindset that they want to be a part of this. This is a wonderful sign, and this is the part where I'm hoping most pediatric doctors are talking to their patients directly and even offering one-on-one conversations. And I always encourage my kids who are getting into the older, the teens to send me direct messages through electronic healthcare. So a lot of kids, we have something called MyChart. I think it's pretty ubiquitous across the country. And I said, if you want to send me a question on MyChart, you can send me a question, and I actually encourage the kids. I challenge the kids to do that between appointments because I want them to start to learn to advocate for themselves and have a direct relationship with their doctor. And this is a perfect age to start doing that. And if the kid's saying, I want to do this, then take advantage of it. I think it's a great opportunity.
Definitely. And if any of you relate to this scenario, we do have a resource at the with the foundation, a fact sheet that's specifically dedicated to communication tips with your doctor. So maybe you and your child could read this together, or maybe it's a resource that you will want to share with them. Is there anyone else who would like to add more to this scenario?
Yeah, this is Tracy. I would.
Tracy.
I cannot stress how important this question is. I would argue that people with OI having a sense of agency and independence is far more important than their ability to walk, or, this is just so critical for further on in life when, they have to advocate for themselves. And I think my parents started showing me x-rays, talking to me about what I wanted. Did I want to continue trying to walk? Did I not want to continue trying to walk? Really hard questions, but things that they really were not theirs to answer. They were mine to answer. And so I think it's really important. I think it's really easy for parents I think it's hard to let go of the control of that when you've been doing it your whole life. You're conditioned to it and whatever. But really, it's one of the biggest gifts you can give your kids is to show them how to do this and model it and start sharing responsibility.
Definitely. Another, resource that the foundation offers, I mentioned before, the office hours, with it being, a virtual setting, you could, for someone who is, 16 and up, maybe you're high school, college age, both of you all can, both the parent and the teen can log on for office hours. And if the parent has a question and the teen has a different question, we can really work together to, to really get to that goal. And again, I'm going to plug it one more time and I'm going to put the link for the sessions to sign up for like the all day office hours in a few seconds. All right, so we are at
Yes, I'm going to interrupt for just 1 second.
Sure.
Lynn Newman asked an interesting question. Are there lists of colleges and universities that are more friendly for OI students? Not that we're aware of, but I think it's a good question. I think this is sometimes where the chats are more up to date than we could ever be. But certainly proximity to somewhere where folks are working hard on delivering OI care at a top level is a helpful place to start.
Definitely. All right, so for our next scenario, I am 14 years old and interested in becoming more actively involved with my care. How do I bring this up to my parents? So the question that we just had for that scenario was from the parent's perspective, and this next one is from the child's perspective of how do they bring it up for getting more involved with their care.
Well, I would say I would encourage this. Like I don't have like a specific feed of words that I would give this person, but I would definitely encourage this person, this 14-year-old, to do so. The range of development of taking on major milestones of participating in one's care happens at various stages of ages. So it doesn't mean you have to be exactly 16 or 17 or 18, or everybody has kind of their own journey. And I would say that if a child is starting to want to ask their questions and participate in care, it could be as young as you want. That child is ready to have more direct conversations with family, with healthcare providers. Yes, they're going to be limited on ultimate decision making, but certainly I would say if a kiddo or a teenager at any age is saying, I want to participate, it's a golden opportunity to engage that kid and to learn advocacy and to speak up for themselves. So I would never turn this away or discourage this based off of a specific age. I would really, really foster this drive from this kiddo.
Sure. Is there anyone else who would like to add to this portion of the discussion?
So I do not see kids who are 14 years old. By the time they come in, they're either 18 or 21, depending on where they transition from. And one of the things that I make sure the kids understand is now that they're adults, unless they give me written permission to discuss their care with their parents, I cannot do that. That they would have to take charge and make sure that they communicate with me directly. And if their mother or father were well-intentioned and actually do care for the individual calls our office, I will not be able to discuss the specifics, and it has to be them to take charge of it. I've, again, like most practitioners, I've had both ends. I've had young adults who come in very well aware of what their history is, what their concerns are, and how we need to address it. And for those individuals, I think transition is a lot more easier. And then there are young adults who come in and they don't even provide history, and they ask their mother or father, like, when was the last time I fractured? What did I have? So for those individuals, I do try to actively encourage them to sort of take charge of their own health.
Great points, Dr. Nagamani.
Last but not least, along those lines, for the parents on the call, there is a website for an organization called Got Transition. And it's more oriented for clinicians, but it's worthwhile for families as well, because it gives you sort of aspirational goals about what to be talking to kids about at different ages. And I think that's really something to bear in mind. Part of our job as parents is to help the kids be independent.
Definitely. And we just put the link to the Got Transition website in the chat. I know sometimes the chat moves pretty fast. So if you, if after this session, you're like, I can't remember the resource that we talked about, feel free to reach out and I can send it out to you.
Yes, and please see the references from Melanie and Michelle about this whole college issue. Lynn, thank you so much, because it really is a big issue, and the chat line is becoming a garden of great information.
Definitely.
Thanks, everybody.
All right, so for our next scenario, I have type 3 OI and deal with respiratory issues. My dad serves as my caregiver. This works well. However, at 25 years old, I'm beginning the process of searching for apartments. I have my own insurance, work remotely, and have worked hard to build a care team that I trust. My dad takes me to appointments and assists with my day-to-day activities, such as cooking and cleaning the house. I am apprehensive about living on my own and having a caregiver outside of the family. Do you have any tips on the process of searching for a caregiver to hire? And if we want, we could circle back around to this question, or if anyone has any tips, feel free, but we can definitely circle back around to this one. Alrighty, for scenario 6, growing up, my mom had this binder with information about past surgeries, doctors I've seen in the past, information on OI to share with doctors, etc. I'm in my early 20s and live on my own. I have the binder that she gave me growing up. How do I decide which information is still relevant? Should I bring this binder to every appointment? Is this binder still helpful? Dr. Nagamani, I know you touched on this a bit during your presentation. Would you like to elaborate a bit more about maybe what is the best method of sharing this information, with your doctor, or how much is too much? Is it, is there such a thing as too much information?
That's a great question. So in my clinic, the things that I typically ask young adults are their recent fracture history, their recent surgical history, and the recent treatment history, as well as the genetic basis of their OI. These, I think, are the most important sort of information that I would want them to have. Regarding the surgeries, the thing that I've made it a point is to understand if they've had any problems with anesthesia, and if they have notes from previous surgery or anesthesia regarding those complications. Those, I think, would be important. A good practice is when you do not know which information to take, the best one would be to take the entire binder to your physician. What I think would really help is if you sort of categorize it yourself by, okay, these are relevant to my bone and skeletal, so this I'll put in one tab. These are relevant to my dental, and I'm going to put in one tab. So if you organize this, it is very easy for the physicians to go through as well. And typically when patients do come up with binders like this, I also do adult genetics. So many of my patients have had evaluations at multiple centers and come with files that are yay big. And so for those, I do pick the ones that would be important and scan them onto the medical records. And I typically do end up making sure that I write that in the first clinic note so that in future, I already have access to the important information from the past. So to be brief, if you have a lot of information, categorizing that information based on what organ system it is and by date would be important when you take it to your physician.
Definitely. So it's safe to say that organization is key when it comes to those binders.
I would be even more blunt. It's like having an encyclopedia at home. It's a good reference, but for goodness sakes, have the maximum 2-page summary, preferably 1. I'm not as nice as Dr. Nagarwani. I have to be more blunt as the surgeon. We are under tremendous pressure to see more patients more quickly, and you've got to make it clear to us as quickly as and easily as possible what the issues are. So just a simple list of surgeries by dates, absolutely. List of medications that you're on, absolutely. Bisphosphonate history, yes. When did I start? When did I quit? Did I quit? Simple stuff will mean that the doctor has time to talk to you. And that's really important. You want the doc to have really paid attention to that information and used it to help improve your care.
Definitely. So maybe not the entire binder, maybe a snapshot or outline with those key points. So I think we have time for one more scenario. I'm 19 and live at home. My parents and I have really found a balance that works for us for navigating care. I've been going to appointments alone since 18. I sometimes feel like I don't ask my care team the right questions. My parents always seem like they knew what questions to ask. Do you have any tips on communicating with your doctor? Tracy, did you?
What a great question. And I think the answer is that the foundation is really helping develop a checklist. And you're the one doing it, really, Jess, and you're doing a great job with the adult care stuff. And hopefully we'll have that out soon. But, part of it is this is your life. And it's time to start communicating about what you care about most. I doubt your parents ever discussed your sex life, bowel bladder continence even. What are the issues that are either helping you or hindering you as you move forward in your life? That's a great place to start. Tracy asked, should you actually send summaries in advance? Boy, don't bother. It's so hard with medical records to keep everything together. At least at my institution, once you hand me those 2 pages, I can put a label on it. I can be sure it gets scanned. I can be sure it becomes a permanent part of your record. If it ends up on my desk as a loose envelope, who knows? Just practical points.
And if I might add, regarding sending the records nowadays, because you can attach it to MyChart, you can send multiple of those. And the good thing about EMR is that we have all the information, but the bad thing about the EMR is that they're not accessible. So if you send 20 different messages with 20 different screenshots, that's going to be quite hard to go back. That's why I said organizing some of these and bringing it to your office visit would probably be a lot more useful for the physicians.
And huge thanks to Barb Simmons. Absolutely. Write down. So you have them on a 3x5 card or whatever on your phone as you come through the door, because we're all intimidated when we see the doctor. Me too. And I'm amazed at the things I can forget. Write it down. Don't be embarrassed. We're thrilled that you know what you want to know, and we can help you with it.
Definitely. And just to plug those office hours again and really using the OIF as a resource, if you want to sit down and chat and maybe, write out questions for your upcoming appointment, we are here. So I'm going to plug those all day office hours one last time. Feel free to sign up with the opportunities to meet with me, and we can really talk through the scenarios that we went over today, or any questions that you may have had that came up during the session. Michael, I'm going to turn it back over to you.
Michael, I'm going to
So,
steal it
Jess,
from you
may-
for 1 second. Nope. Please, please, please be sure to sign up for our listening sessions as we work through our project on transition and access to quality care for adults. We need everybody's input, and we want to hear what you have to say. Sorry, Michael.
Oh, no, absolutely. I was just going to say that I want to thank all of our panelists for joining us here today. I want to thank all the attendees who are with us it's the morning on the East Coast, but we really appreciate people giving their expert perspectives on this complex, dynamic topic. This is a topic that OIF cares deeply about. It's something that we are actively investigating and trying to learn more about that so we can better serve our community. I put a link into the chat just a few minutes ago with a link to the virtual conference webpage with the links to the other Zoom links for today's session. The next upcoming session will be a research update, also with Dr. Tosi and Dr. Brendan Lee, about the current work that the OIF is doing around osteogenesis imperfecta care. Thank you all again so much, and we look forward to seeing you in the future.
So, Michael, before we end, can I make one recommendation? So, what Jessica brought about regarding some of the resources that you have that are typically beyond the expertise of the medical sort of community, providing practical guidance, transition guidance for patients, and taking control over their own charge. That would be a great topic for the OI Teleecho series, wherein the speaker would be from the OIF, and the people who will be listening will be all clinicians, because I for sure do not know the answers to many of the questions that are asked regarding that. So I just wanted to put that bug in your mind, Michael.
Yeah. Very interesting. Yeah, absolutely. Great. Well, thank you all so much. We want to not hold everyone up for the rest of their day, and we will hopefully see you all in just about 15 minutes at the next session. Thank you all so much.